NRP instructor exercise subjects and these of journals ability of certain at the at Qatar. Over to you, sir. Sir, no.
Hello, can you hear me? आवाज कट रही थोड़ी सी. Hello. Let me change.
Yes, Dr. Naveed, we can hear you. अपनी screen full कर ले.
Can you hear?
Yes, sir, we can hear you, and we can start now.
Okay, Bismillahirrahmanirrahim. Thank you, Dr. Said, for nice introduction. So as you can see, today's the topic of discussion and presentation is approach to surgical abdomen from the neonatologist perspective. So I don't have any conflict of interest, and my main focus in today's presentation will be on the bowel obstruction, and but I will not discuss necrotizing enterocolitis, their surgical neck, as well as anorectal malformation and esophageal atresia. So the objective of my talk is first to classify and pathogenesis of bowel obstruction, clinical features, which is more important from the neonatologist and pediatrician. And the main focus of today's presentation is how we can diagnose the bowel obstruction based on the radiological features. And some points will be discussed on the preoperative and post-operative management and monitoring. And finally, I will touch base few things on gastroschisis and omphalocele. And in the end, we will have some interactive session on MCQs that will be most interesting part of my presentation. So before we go in detail about the bowel obstruction, it is very important to understand and make a concept about the embryological part of it. We all know that during the period when the fetus is being formed, the bowel herniate outside and then reherniate inside of the abdomen. Why it occurred? Because the bowel is a rapid growth as compared to the rest of the body. So in the first stage, which is 90 degree, the small intestine during their herniation go to the right and colon to the left. And in the second stage, which is further 180 degree turn, where the small intestine turns to the left and cecum below to the liver. And the final stage, where there is a further descent and fixation of the cecum and ascending colon. So if you can see in this picture, in the first A part, C stands for the celiac artery, then the superior mesenteric artery and the inferior mesenteric artery. And then there are three subsets, foregut, midgut, and the hindgut. So if you can see, the foregut is herniated outside mainly, and then it returns slowly to make a 270 degree turn. And ultimately you can see this is the final position. To make it more clear, if you can see here in the first degree, after 270 degree rotation, this is the final what we normally see in our anatomy and the pictures. And these aesthetics, this aesthetics point to the cecum, and this is the DJ duodenojejunal flexure, and this is the superior mesenteric artery supplying the small intestine and the colon. And if there is incomplete rotation, then you can see the cecum is not in the proper position, and the DJ flexure is also abnormal, and there is a band which is compressing the intestine. And if there is non-rotation, you can see a picture something like this. One important thing to mention in the beginning of this presentation that it is important to distinguish and do the diagnostic investigation in terms of dividing the obstruction in high and low level and not by the small and large bowel obstruction. The reason is that on plain radiograph, you cannot differentiate between the two because of the featureless nature of the intestinal loops. There are many classifications for the bowel obstruction. We can divide them into medical and surgical reason and also into anatomical and pathological variant. So I have divided them into these two for the ease of understanding. So first, from the anatomical classification, we can divide them into high intestinal and low intestinal obstruction. And in the high intestinal obstruction, we have duodenal obstruction and jejunal atresia. And duodenal obstruction, you can further divide into atresia or obstruction by annular pancreas or malrotation with the Lands band. And the low intestinal obstruction can divide them into ileal atresia, meconium ileus, meconium plug, or small left colon syndrome. As far as the pathological classification is concerned, you can divide them into intraluminal, extraluminal, and functional. And intraluminal when there is something inside the lumen like atresia or meconium ileus causing obstruction, or extraluminal when something obstructing the bowel from outside, for example, Lad's band, and functional when the function of the bowel mucosa and the muscles are itself not functioning, for example, in the Hirschsprung disease. So I know that you all knows about this, but just to go through atresia when we talk about is that one end, both end of the intestine are closed and blind pouch. Stenosis is something which is narrowing the bowel segment. And when there is a web, you can see that it also causing obstruction with the dilatation on the proximal and the narrowing on the distal. Windsock deformity is like a billowing of the web of the tissue like this. You can see mostly windsocks in the airports where there is a orange thing to tell us about the wind direction. Then there are certain adhesive bands which outside obstruct the bowel. Volvulus is twisting of the bowel, and this is very dangerous, and it is quite an emergency. Whenever it is diagnosed, you have to take the baby straight to the OR. And then meconium ileus, in some babies, the large meconium plug, for example, here, obstruct, and then it will cause pseudo-obstruction. And then annular pancreas, which sometimes encircle the duodenum and will cause obstruction to the bowel. So it is very important to understand the pathogenesis and reason because it will help in the management as well. So we all know that duodenum is derived from the foregut and partly from the midgut. And early in the gestation, the endothelium proliferate and cause intestinal occlusion. And this occlusion is later on recanalized by 7 to 10 weeks. And second part of the duodenum is last to recanalize. And this is the region which is most common to problems and cause obstruction. So we can say that whenever there is duodenal atresia, it is the recanalization defect. And mostly because it is single, it cannot be multiple. And as far as the jejunal and ileal atresia is concerned, it is always secondary to vascular event. If you can see here, this is a mesentery and these red lines are the vessels. And if there is any obstruction to the blood supply to any part of the segment or whole bowel, it may cause narrowing and obstruction. There are 4 types based on the anatomic characteristic, and we can go further. I will show you the picture in the next slide. And there is no mechanism about how clonic atresia occur. You can further divide duodenal atresia into 3 parts. One is the diaphragm within the duodenal lumen creating a windsock effect. This is more clear. You can see this is a membrane and the narrowing segment is this one, and this is the dilated proximal part of the duodenum, and this is called type 1. The type 2 is when there is a fibrous band which connects the proximal and the distal duodenum. And the type 3 is when there is a complete separation between the dilated proximal duodenum from the collapsed distal one, like this. Type 1 is more common. And this is the gross field classification. I think from the medical point of view, it's not that important, but just remember that type 1 is more common and the type 3 is least common. So type 1 is when there is just like the lumen which is obstructed by the membrane, but the continuity is but there is no continuity is maintained and there is no discontinuity. Type 2 is when there is a fibrous cord between the dilated and the distal prox and distal narrow segment. You can see this is a cord connecting between the two. And type 3 is further divided into two parts. One is when there is complete separation and there is a V-shaped mesenteric defect. And type 3B, which is apple peel deformity, when there are two different segments where is complete atresia of the proximal, but they have both blood supply and there is like a peel, like you can see the apple peel, that is the word given to it. And type 4, when there are multiple atresias like this in the segment connected by the fibrous cord. So how do the intestinal obstruction present in the neonate? You can present, like the baby can present in a low bowel obstruction by failure to pass meconium by 24 to 48 hours and with abdominal distension. Just keep remember that the more distal is the obstruction, more pronounced is the abdominal distension. And we all know that meconium should be passed by 48 hours of age. And if the baby is not passing by that time, it's always concerning and we have to investigate. And the high bowel obstruction, they usually present with the bilious, with the vomiting, which can be bilious and non-bilious. And as we know in the group that always proceed with history and physical examination, make your differential diagnosis, and then target the investigation. So whenever a baby presents with those symptoms, it is important to take a history and see whether antenatally there is history of polyhydramnios, any bowel distension, or bowel wall echogenicity. And in the postnatal history, please ask about the vomiting, especially the timing of the vomiting, whether it is green or not green, and when the baby has passed the first meconium, whether the baby is jaundice or no, any associated extra-intestinal anomalies, and family history of bowel obstruction. Physical examination is also very important. Apart from vital signs, it is important to see the respiratory compromise, because abdominal distension, which might be massive, can result in the elevation of the diaphragm, and that reduce the functional residual capacity and result in tachypnea. And also look for the signs of volume depletion, for example, oliguria, dry mucous membrane, skin turgor, and sunken fontanelle. Look for the jaundice, especially the direct jaundice on the lab investigation. Look for associated congenital anomalies, and also from the perineum to look whether the anus is patent or no. Very important examination, not to miss in any newborn. And then, as I said, in the abdominal examination, the more distal is the obstruction, abdomen is markedly distended with visible or palpable loops. And the more proximal obstruction, there is less distended abdomen. Also palpate for any mass, tenderness, erythema, and bowel sounds. And it is important that the tenderness and erythema, they occur quite advanced, that occur at a quite advanced stage. So it is better to diagnose earlier rather than the things go beyond that stage. And always look for the hernial orifices to look for inguinal hernia. This is just like a picture to show you that this is a baby who is quite distended abdomen. And which I said that the more distended abdomen, it looks to be having a distal obstruction. And this baby also having this bilious colored vomiting as well. So once you have diagnosed that this baby might have intestinal obstruction or surgical abdomen, the baseline investigation needs to be ordered like complete blood count and differential to look for hemoglobin platelets, especially for thrombocytopenia, and the absolute neutrophil count to look whether there is any sepsis element, total and direct bilirubin fraction, serum electrolytes, blood urea nitrogen, creatinine, and this is important to assess the fluid and electrolyte balance. Blood culture, if sepsis is suspected, and then blood glucose, blood gas to look for metabolic acidosis, glucose for hyperglycemia, and the lactate. So these three serial investigations might help you in whether the child is deteriorating or no, when the lactate is seriously rising and the glucose is also high and there is progressive metabolic acidosis. Blood type and the antibody screening coagulation studies needs to be done pre-op. And then on this right side, there are special investigation you can order, not in every case, but it is better to have those investigation from anesthesia point of view, because in our hospital, every baby who go for surgical correction, they ask for echocardiogram. Chest radiograph needs to be done to look for vertebral anomalies, renal ultrasound to look for associated renal anomalies, and then special investigation like rectal biopsy for particular cases of Hirschsprung disease, cystic fibrosis workup, especially when the baby have delayed passage of meconium and meconium plug syndrome is suspected, and sweat tests later on, and the genetic consultation in suspected cases for family history. So now these are the important thing, because any pediatrician who is sitting in the remote area, only the abdominal X-ray is the main investigation that he can do and decide about whether this baby needs emergency referral or he can wait for at least 24 hours. And the most important is the abdominal X-ray, which is done to look for the pattern of the gas. So if you can do an abdominal X-ray immediately after birth, it will be gasless. And by usually 1 hour, the gas reaches to the duodenum, and by 24 hours, it reaches to the rectum. Also in the abdominal X-ray, you can look for bowel dilatation, diameter of the bowel, and you can compare it with the interpedunclar width of L2 vertebra. Then based on the abdominal X-ray, you can look for whether further investigations are required, mainly which is the fluoroscopy, in which the contrast is given, and we look for the further things which we will see later in the presentation. Now, currently the ultrasound is getting more and more popular, but it is operator dependent, and not every unit and every person is good in reading it. There is very limited, or I can say no, role of CT scan and MRI in the bowel obstruction. So whenever you order an image, always mention whether you are doing the AP view or lateral decubitus or left lateral decubitus and cross table view, and look for bowel distension, air fluid level, free air, calcification, and mass effect. And the rationale for doing the contrast study is to demonstrate whether there is microcolon, demonstrate the colonic patency, and for the screening for functional obstruction. I've just, this X-ray, I found it out of the article, which is interesting to see which areas is the stomach, ascending colon, cecum. So this is just to look for the particular bowel in that particular segment in a normal anatomy. So let's start about the important aspect of this presentation. So we have now taken the history, physical examination, and now by this stage, the doctor must have decided whether he or she is dealing with the benign cause for distended abdomen, for example, gastroesophageal reflux, but on the extreme, he or she has to differentiate it whether this is an acute abdomen and urgent surgical referral needs to be done. So in the abdominal X-ray, it is important that we can differentiate about 8 patterns to look for the surgical abdomen. I can go further in my presentation for explanation. We need to identify 5 patterns on the upper GI contrast. One is to see the DJ junction should be on the left side of the spine. And if it is not, for example, in this, it is on the right side or just on the middle, then this needs to be, that show that there is malrotation. Or if there is a corkscrew type upper GI, this is an emergency. And these are the further 2 where there is blind end of the duodenum, or there is a smile fibrous cord. 4 pattern needs to be understood when there is a contrast enema to be done to look for the whole large bowel and to see whether it is tapered at the splenic end, or there is a transition zone, or there is a whole colon which is microcolon. So we'll go in each pattern individually now. So the aim of abdominal X-ray is to look for normal versus obstructed bowel, and the possible finding one can find on the abdominal X-ray is whether there is a single, double, or triple bubble appearance. So once you have diagnosed that this is a single or double bubble, that means that you are dealing with baby with a high bowel obstruction. So once you are here with the high bowel obstruction, your aim is whether this baby needs upper GI or no. And if you find there on the abdominal X-ray, there are many bubbles, for example, in this X-ray, which multiple cubes, or there are or like a sequence tubes are there. So if this picture is there, it means that you are dealing with, say, somehow low bowel obstruction. And in that water contrast, enema needs to be done. So if there is upper bowel obstruction, next question is to see whether there is a distal gas or no. If there is no distal gas, for example, in this X-ray, it means that the insult occur in utero, and you have a time to refer the baby if you are not having a pediatric surgery facilities as an elective surgery into the tertiary care. If there is a double bubble, there will be a duodenal atresia, and if there is a triple bubble appearance, there might be a jejunal atresia. And this is when there is no distal gas distal to the double bubble. However, if you find a gas distal to the bubbles, it means that the insult occurred quite recently or incomplete. And you might be dealing with emergencies like malrotation with volvulus or duodenal stenosis or web. And in that case, an urgent upper GI investigation needs to be ordered. And if you remember, 5 pattern needs to understand on upper GI. If there is a corkscrew appearance like this, you can see it means that there is a malrotation with volvulus. The moment you diagnose this, the baby should go straight to the OR and do the emergency laparotomy to untwist the bowel, because here the minutes count, otherwise whole bowel will be dead. And if you find that there is no corkscrew, but there is a DJ junction, which is on the right side of the midline, it means that there is malrotation without volvulus. And you can also see a windstalk deformity as well on the upper GIS. These are just few X-rays. You can see here is a triple bubble appearance. One bubble is this one, second and the third, which is consistent with the jejunal atresia. This is a double bubble appearance for duodenal atresia. And this is also the triple bubble appearance, one of the X-ray for one baby. This is the contrast study. If you can see here, the white arrow is telling us that the DJ junction is not on the left side. And in the lateral X-ray, you can see that there is a corkscrew appearance, and this baby on the laparotomy turned out to be malrotation with volvulus. Now, coming to the distal bowel obstruction, this is a common X-ray which we can see with the cubes and gas pattern. And if you can see this type of X-rays, it's like tubes, it means that something is wrong with the lower bowel. How to proceed with this? You have to do the contrast enema after doing these X-rays. So if the X-ray is having cubes and the history is suggesting that there is no bilious vomiting, then it may be normal or maybe underlying sepsis or some functional defect like maybe electrolyte imbalance. However, if they find the pattern on abdominal X-ray with the cubes and the baby is symptomatic with bilious vomiting, it is always better to proceed with the upper GI investigation. On the other hand, if the abdominal X-ray is showing pattern like tubes, diagnosis of lower bowel obstruction, and here water-soluble contrast enema is indicated. And you can find whether there is a transitional zone. In that case, look for the reverse rectosigmoid ratio. Like this, the sigmoid is quite big and the rectum is small. It means that you're dealing with Hirschsprung disease. On the other hand, if you can find there is no transition zone, but the left colon is small, so that may be a differential of small left colon syndrome or Hirschsprung disease. And elsewhere, if you find a small colon, it means that there is a whole colon, which is microcolon, which is on here. If you can see, the whole colon is small. Then there is also to differentiate whether the ileum is distended or no. If with this contrast, the colon is visualized and somehow the contrast goes and distend the distal ileum, it means that there is meconium ileus. However, if the colon is visualized and the ileum is small, that predict that might be having underlying ileal atresia. So just a picture to tell about the Hirschsprung disease, which is a functional aganglionic segment of the bowel. So these yellow areas is just to show that these are the innervated gut. And when there is no nerves, the area of the bowel is collapsed. So this area will be collapsed looking on the barium studies, and the proximal area up till where the nerves are innervated will be distended. And just to tell you that these innervation occur from craniocaudal direction and not from below upward. So if you find a transition zone here, it means that all the distal segment is no nerves. And these are just the few X-rays finding I can show you about this, the transitional zone in a patient with Hirschsprung disease. And this is the contrast enema, which you can see a small colon is being demonstrated. This is another picture to see. This is a sigmoid colon distended, and this is the rectum, which is narrow, and this is the transitional zone. Another important topic for discussion whenever there is a lower bowel obstruction is the meconium plug. You can see here when the meconium is stuck in the bowel, then the flow of the content of the intestinal wall is stopped, and that result in obstruction. And the typical appearance on the contrast study, you can see a filling defect like this. If you can, I can see here this one. So once you have this type of pattern, it means that it is a meconium plug or meconium ileus. And the distinction is very important because this is medically managed, rarely surgical. And if it is not, then the surgery has to be done. So hopefully by this stage, you have made a tentative diagnosis. Surgeon has been alerted. So as a pediatrician or neonatologist, from the medical perspective, it is important that the pre-op management needs to be done, because this is our duty, feedings to be held, a wide bore NG tube or orogastric tube is placed and aspirated. Intravenous hydration should be provided, and abnormalities in sodium and potassium needs to be corrected. If the NG aspirates are loud, that needs to be replaced with normal saline and potassium chloride. Always the baby suspected of intestinal obstruction should be put on broad spectrum antibiotics to include the gram-positive, gram-negative, and anaerobic cover. This is because the stasis can lead to translocation and result in sepsis. Then the temperature control needs to be maintained. If there is any coagulation abnormalities, especially INR, that needs to be corrected with vitamin K and FFP. Always, it's better to arrange for the cross match. Consent needs to be taken, and always update the parents. In the post-operative care, always maintain the hydration and IV fluids, and monitor for urine output. Keep NPO for a specific duration as per the surgeons. NG drainage and replacement fluids continued. Very important to control the pain and sedation. Antibiotics to continue. And depending on the surgical advice and the type of surgery, we need to tailor the ventilator management extubation plan, and if there is any contraindication for NIV. It is always important to look at the post-operative notes, and after all the initial management, it is better to update the parent. Usually the surgeons needs to update the parent, but sometimes they are busy in the OR. So it is our duty to update what procedure has been done and what are the future management. So we are not interested in the procedure which is done, but these are the common things which are being asked in the examination about what is LAD procedure and what things are being done. So I just include these slides. Whenever there is a LAD procedure, there are 5 things needs to be done. One is the we have to untwist the torsion, divide the LAD band, and then widen the mesentery and fix it. And then they also do the appendectomy. It is important that if the LAD procedure has been done and appendectomy has been done, to document in the notes and also tell the parents as well, because this one has consequences later in the life, because later once he is adult and has abdominal pain, so that the physician may not confuse it with appendectomy because appendicitis, because appendix has already been removed. And finally, the position of the cecum is to the left and the small bowel onto the right is maintained. Sometimes the baby come with the stomas. So there are 2 types of stomas. One is the loop, in which the bowel segment is brought out through the abdominal wall. And the other is the double-barreled stoma, which is a temporary with 2 openings, distal and the proximal. And the third one, depending on which type, is the type which is being made, whether high level or low. Most of the stoma which are being made in the jejunal area, they are high output stoma in which the output is more than 12 ml per kg, and that require replacement. Whenever the stoma is being made, it is important to assess the stoma post-operatively to look for the color, appearance, its protrusion, whether it is prolapsed or no. Look at the mucocutaneous junction, skin around the stoma, as well as the wound to look whether there is any exudate infection of the surrounding skin and pain later on in the NICU. So monitoring, whenever have a baby with a stoma, it is better to monitor frequent and regular electrolytes and fluid status. We usually hear in our hospital, those babies on stoma, we frequently check their urinary sodium. So normally it is between 20 to 40 millimoles per liter and need replacement if it is low. Acid-base status needs to be maintained. Growth is very important in such babies. Nutritional needs also very important. Refeeding, once the bowel sound returned and the baby started feeding, at that certain stage, we refeed from the proximal stoma into the distal stoma in order to make the length of that segment enlarge. Always watch carefully for these babies for sepsis, because translocation is very common in such babies. And obviously look for the complication, especially related to TPN. And finally, just to show this important that to gastroschisis and omphalocele, between two, the incidence we can see 4.7 per 10,000 live birth for gastroschisis and 1.9 in omphaloceles. Gastroschisis babies are having rarely associated with other congenital anomalies, but more commonly it is in relation to omphalocele. Complications for gastroschisis are mainly intestinal, but in omphalocele it is extraintestinal, and the site of the defect is right paraumbilical in gastroschisis, while central umbilical in omphalocele. The sac is not present in gastroschisis, while always it is present, but it can be ruptured as well. And in gastroschisis, usually gut, stomach, or liver are extruded, and occasionally other organs are there in omphalocele. It is very difficult to manage post-operatively baby with gastroschisis because the feeding issues. This is because the bowel is already exposed to the amniotic fluid, and it is that affect its motility. That's why the feeding is quite challenging in such babies. However, not such thing is observed in the omphalocele because it is covered with a sac. And usually the mortality is about 5 to 8% in gastroschisis, while it is high if it is associated with other association in omphalocele. This is how it looks like. Omphalocele, which is a sac there, and gastroschisis looks like this. Please note the orientation of the umbilical cord. So whenever a baby with a suspected omphalocele or gastroschisis is planned to deliver, it is better to alert the surgical and the neonatal team. It is important to do a pre-delivery huddle and make sure that the supplies are available, especially the wet gauzes and the polythene bag. Sterile gloves are available. Usually follow the NRP and avoid PPV or CPAP in order to avoid distension of bowel. And intubation is always preferred if ventilation is necessary. Delayed cord clamping can be attempted if the baby allows. And always we keep the umbilical stop at least 10 centimeter long, which can be required later on for sutureless closure. Avoid unnecessary handling of the bowel. Immediately place the baby in the polythene bag, give vitamin K, put a wide bore French 8 or 10 replogable tube, and as soon as possible, transfer the baby to an ICU, and always nurse the baby on the side position on the right side to avoid pressure on the bowel. Otherwise, it may cause ischemia because of kinking of the mesentery, and it may quickly discolor the bowel. Quickly do the preoperative order, establish an IV line, preferably on the upper limb. Fluid and electrolytes needs to be checked. Babies with gastroschisis, they are at risk for evaporative losses and third spacing. Immediately ask the surgeon to come at the bedside and have a look on the bowel color, and further management needs to be discussed with them. Pain management is very important, and initiate antibiotics and also family support. Usually, if you can see here, this is a silo drain in which the surgeons put. Sometimes the bowel are outside and it is not possible to put all the bowel inside. So the surgeons, they just put the bowel in the special dressing called silo. And then in the coming days, they slowly push it down depending on the cavity of the abdomen, because they cannot put everything inside, otherwise it will result in compartment syndrome. So this is my final slide. Whatever I have discussed, it is being summarized in this table. And I can share this presentation later in the group and you can read it. Thank you. So now, what is the time? So we will discuss now with some questions and answers. So I'm not sure, Vikram, how can we proceed?
Yes, sir, we have good time, so we can do it.
So before we do the question answer, should we do the question, quiz?
Yes, I think.
So can I show it on my presentation here, or how
Yes,
we
yes.
will?
We will show it in the presentation in the screen, and we will request the responder to leave your comment in the question answer section, which is given at the below, looking like a text type.
Okay, so let's start. So the first question is, this is an abdominal X-ray of full-term newborn with feeding intolerance. So which of the following diagnosis is not consistent with the X-ray finding? A is diaphragmatic hernia, B, esophageal atresia with upper pouch fistula, C, gastric atresia, and final is isolated esophageal atresia. So if the participant can write it in the question and answer.
Yes, and if in 1 minute nobody's answering in that, and someone want to answer it live, so he can answer it well, and we can also request someone to please all to participate, please. Before we will request residents and fellows to respond.
Any volunteer, or you can type it on the question answer and see.
Sarish, can you tell about this X-ray and can you answer this question? Anyone want to respond on this?
Yeah, we try to make it interactive with this question in the Zoom, but that was not working.
Dr. Sitara, can you answer this?
Vikram, somebody wrote C in the question answer. Naveed, somebody wrote C in the question answer.
Okay, that's good. Okay, we can.
And
So that's correct.
Dr. Sitara answered A. So what is the correct answer, Dr.?
So the correct answer for this question is C, gastric atresia.
Yeah.
Because A is not correct because you cannot see the chest hair. And if you have not been shown chest hair, so this X-ray can be diaphragmatic hernia as well. B, yes, it can be esophageal atresia with upper pouch. And isolated esophageal atresia can be there, but it cannot be gastric atresia. Whenever we say gastric atresia, it means that we are always discussing that it is obstruction at the pyloric and not at the antral. So gastric atresia is always obstruction at the pyloric and there should always be a bubble. So if you have seen in my initial few slides, single bubble or double bubble appearance. So if there is single bubble, that consistent with the gastric atresia. I hope it is clear. Okay, we can go to the next.
Yeah, the
because the esophageal atresia, the lower esophageal sphincter or atresia can go, it cannot, it can go with that X-ray, as you mentioned. But the gastric atresia, you have to have some bubble or single bubble because it's on the distal end of the stomach. It's very clear. I hope
Okay.
it's clear to everybody.
One thing I want to point out here, as we can see on the left side, lung is visible.
Yeah.
But it
So,
could be right-sided diaphragmatic hernia.
but it could be. That's it. Thank you.
No, a diaphragmatic hernia, as Naveed said, we cannot, without the chest X-ray included. Okay, I mean, I think whoever said diaphragmatic, he or she think about the scaphoid abdomen or empty abdomen. Abdomen is look full in it or something like that. But chest X-ray has to be there to to make it this point. So anyway. Yeah.
Okay, so it is important that you participate in these question and answers. It will be your learning.
Exactly.
Okay, we can go to the next question.
Hello, Dr. Naveed.
Yes.
Can you hear me?
Yes, yes.
I think that was a nice MCQ, but as a generic rule, if something is not shown in the X-ray, you cannot assume that. So I agree with you that because the chest has not been shown, so you cannot assume that. This is what I think.
But then you cannot say that this is gastric atresia
Yes,
X-ray.
yes, yes. No. I'm saying that if somebody says diaphragmatic hernia, you rightly said that because it has not been shown. So in MCQ solving techniques, if something is not shown, which is not there, you can't assume. So if the lungs have been shown in this, that's a different story. But because
Of course,
you have
yeah.
hide the lungs, that's why we cannot assume. So I agree with your point.
Because in MCQs, there is always a dodge as well. So this is just like a dodge.
Yeah. Thank you.
Oh, so this baby is born by vaginal delivery at 36 with gestational age. Delayed cord clamping was performed for 30 seconds. So what do you think this baby is at risk for? A, chromosomal anomalies, B, polycythemia, C, hypoglycemia, D, cholestasis, and finally E, bronchopulmonary dysplasia. So did somebody reply or no? Vikram, can you see in that, because I cannot see in the question?
No, nobody replies so far.
Yes, sir. One is reply. It's according to her, it's B.
Who?
So someone is reply. It's B.
B or D?
Polycythemia. Polycythemia.
Polycythemia.
So, see, can you tell what is this X-ray? What are the findings? Findings
Yeah,
of
Dr.
the
Dr. Said, you will volunteer and you tell us what is the X-ray you can see. What is the underlying condition of the baby?
So it seems to be the bowel loops is out, protrude outside. So,
Exactly.
So it's most likely, as we discussed a few minutes back, it's most likely it's gastritis. So
yes,
and
I mentioned what is the risk for these babies can have.
Yes, it's a chromosomal anomaly. We can one of the risk factors at the risk of maybe. So
no. That's why I presented that table. Again, for time constraint, let me say. So the correct answer here is D, cholestasis. The reason is that I said these babies are at risk for feeding challenging and on long-term TPN. Chromosomal anomalies in the gastroschisis is rare. It's mostly in the omphalocele. And then polycythemia, I don't know why someone said polycythemia. any term babies, it's not a risk for polycythemia. Hypoglycemia, there is no clue that mother is diabetic or any other clue here. And 36-weeker obviously will not have bronchopulmonary dysplasia. So I hope this has cleared the answer.
Yes, sir.
Let's go to the next.
Sure, sir.
So it's simple as well. A term female newborn developed bilious vomiting at 48 hours of age. She has not passed meconium and her abdomen is distended. Physical examination shows a normal appearing perineum and no other anomalies are apparent. Of the following, the most likely diagnosis is annular pancreas A, B is anorectal malformation, C is duodenal atresia, D is Hirschsprung disease, and E, jejunal atresia. Anyone can reply, it's fine. We are all learning. I'm learning from you guys.
Dr.
someone-
Sari,
Sarish reply is duodenal atresia, and second, Dr. Samita is there. She's saying it's D, Hirschsprung disease. Only two. Anyone else?
Actually, yeah, whoever applied, they can open the thing and they should tell us why they
Why
are
they
choosing
think,
that.
yes.
Yeah, then it is more fruitful for all of us. If somebody choosing Hirschsprung, so what is in their mind? If somebody choosing duodenal or anorectal, duodenal atresia somebody choose. So why they choosing those diagnoses as compared to the others? This, I mean, no shyness, nothing. Yeah, walaikum assalam.
Sir, as for me, there is a history of bilious vomiting. That's why I chosen duodenal atresia. While the kid could have like coexisting Hirschsprung disease, that will be revealed later on by other investigations as well. So, as per me, this is the most probable answer.
Thank you, Dr. Sarish.
Thank you.
Anyone else?
Dr. Samita,
Dr. Samita.
you can unmute yourself. You can talk.
Okay.
We got
we can-
few other answers. D, and Dr. Aska is saying duodenal atresia due to bilious vomiting. Dr. Sitara is saying C, duodenal atresia, and Dr. Osman is saying D.
Assalamu alaikum, sir. Sir, it's me, Wahidullah, sir, here. Sir,
Right.
Hirschsprung, the reason is that I guess the vomit has started a bit later. It took 48 hours for the patient to start vomiting. I guess in duodenal atresia, the patient will start vomiting soon, I guess on the first day of life, because it's more on the higher side.
You are
Exactly.
right.
Excellent. So
Yeah.
that was a catch here. Here, term baby who is presenting with vomiting at 2 days, it's too late to diagnose duodenal atresia by that age. The main clue here was that the baby didn't pass meconium and has distended abdomen. So A, B, C, and E is ruled out, and only thing left is most likely is Hirschsprung disease. Some may question that why jejunal atresia is not there. So in the book, it is mentioned, and we have observed here as well, that jejunal atresia most likely behaves same like duodenal atresia. If there was like ileojejunal atresia, then the thing would have been different, but here is typical jejunal atresia. So the most likely diagnosis here is Hirschsprung disease. Oh, I have to end show and then because I cannot read it. Can you read it as well, right?
Yes, sir.
Okay.
A mildly dysmorphic
Okay, I will.
3-day-old full-term infant
So go
failed
back
to
to
pass
Go ahead.
meconium.
Yeah.
Yes, sir.
Yeah, continue, Saeed.
Yes, sir. A mildly dysmorphic 3-day-old full-term infant failed to pass meconium. An initial evaluation reveals the following abdominal radiograph. Reasonable interpretations and next step includes all of the following except number 1A, a barium enema should be arranged Number option B, an evaluation of associated physical findings may aid in narrowing the diagnostic possibilities. Number C, given the lack of air in the rectal area, a digital examination should be performed to check the presence of stool in the rectal wall. Number D, the abdominal radiograph suggests a distal obstructive pattern. 3 day old बच्चा है, माइल्डली डिस्मॉर्फिक है, फेल टू पास किया है मिक्योनम, और ये एक्सरे हमारे सामने है। तो इनमें से जो जो स्टेप्स हैं हमारे, उनमें से कौन सा स्टेप जो है वो नहीं जो है हम इसमें करेंगे?
It's a very important question. I think we don't have any time, so we can proceed quickly.
Anyone want to comment? Dr. Sarish, Dr. Stara, Dr. Waheed, Dr. Samita. Yes, Dr. Osman is there. He's saying it's C. Given the lack of air in the rectum area, digital examination should be performed to check the presence of a stool in the rectal wall. And another answer, Dr. Osman ने किया है. Anyone else who want to reply or give answer? Dr. Samita, it's D. Abdominal radiograph suggests a distal obstructive pattern.
So the correct answer for this is C. We don't have to do the digital rectal examination in babies, especially when you're suspecting Hirschsprung or functional, because it will distort the transition zone. So if you remember, I said in my presentation, when you have this tube-like pattern, always it is lower or distal bowel obstruction. So the rest of all the options were consistent that we have to do in this baby, except C. Let's go to the other.
Yeah.
So a full-term
Should I read?
Huh? I read. You can read. Let me put on the show, because there is a bar on my top, so I cannot read it.
Okay, sir. Thanks, sir.
Yeah, go ahead.
A full-term infant is sure, sir. A full-term infant is admitted to NICU because of physical examination, finding of a tense, distended abdomen. The infant is otherwise stable. Without the nasogastric tube is placed to decrease the infant.
Can you hear me?
Yeah, I think we can hear you, but the person
I-
who's reading is lost. Anyway, go
Oh.
ahead, Naveed.
So if you can see here, this baby's X-ray, the abdomen, if you can see the flanks and the gasless, so it's mean that there is a floating bowel. Ascites is there on this, and the bowel is in the center. So it means that there is something quite chronic going on. So part of the following, the most accurate here would be the surgical intervention is likely. The clinical picture abdominal do not suggest obstructed pattern. No, it suggests, because if you can see, there is on the left and the lower right, there are few calcifications as well. So it means that this baby has perforation in utero. That's why there are some calcification, and now this distended ascites as well. B is wrong, because babies, if it is meconium plug, there is not chances of greater than 50. It is always about like 10 to 15% chances of cystic fibrosis, less than 50%. And always when there is ascites, obviously the renal cause has to be ruled out. But here, because of the calcification, it is not renal, it is because of the perforation. Let's go to the next. So the fellow is called at the bedside of a preterm infant with abdominal distension and inconsolable crying. On examination, the abdomen is distended and slightly firm. Active bowel sounds are present. Abdominal X-ray is shown here, which is the preferred next step in the management of this baby. A, call the pediatric surgeon to evaluate the need for surgical intervention. B, take a cross-table or decubitus abdominal X-ray to rule out pneumoperitoneum. C, place a replogal, make baby NPO, obtain CBC blood culture, and begin antibiotics. And finally, D, reassure the nurse that the findings are normal. So which one will be the next step you do?
नवीद फुल स्क्रीन कर लेंगे आप थोड़ा ताकि विजुअलाइजेशन क्लियर हो और अगर एक्सरे भी प्रोमिनेंट और कर सकते हैं ना देख लें अगर आप उसको एक्सरे को
एक्सरे जो है ना उसमें है पावर पॉइंट में तो उसको मैं ज्यादा इनलार्ज सिर्फ फुल स्क्रीन ही है ये
So what is the diagnosis? Can anyone tell what is the problem over here in this X-ray? Residents, fellows. Dr. Usman, this is for you. You can unmute yourself. I think he is busy. Why?
Anyone replied in the question answer or no? I can go forward.
Sir, it seems like distal obstruction, tubes, cubes.
So what option you will take?
I think call the pediatric surgery to evaluate the need for surgical intervention. Yes.
Dr. Furqan answered that it is inguinal hernia.
Inguinal hernia?
Yes.
Yes, it's important that this X-ray is consistent. If you can see, the bowel loops are in the scrotum. So someone is dealing with the incarcerated hernia. So the option is right that you need to call the pediatric surgeon to evaluate the need for surgical intervention. Means that baby is having some obstructed hernia. So that needs to be relieved. Look at the question: inconsolable cry, abdominal distension, firm. Okay. Let me end the show and then I can enlarge it later. So this is the X-ray for 2-month-old former 26-week gestational age baby who has repeated bouts of abdominal distension and non-specific abdominal X-ray finding. A barium study is done. All of the following clinical scenario are possible in this baby. Clinical scenario, except A, the diagnosis of Hirschsprung disease. B, at 4 weeks of age, the infant had neck that required surgical intervention. C, at 4 weeks of age, the infant had neck that required medical management. And D, previous repair of jejunal atresia. So there is one wrong answer.
Can anyone tell what is the study? This is studies.
Sir, this is contrast studies, contrast enema.
And then what you can see and see which one is the wrong answer here. Former 26-week or 2-month-old now. X-ray is non-conclusive. Okay, I think I can tell.
Dr.
So
Furqan is saying A, it's A according to Dr. Furqan Salim, sir.
Yeah, he's
and
right.
the answer is Dr. Sara, he's saying A.
Yeah, So A is a wrong answer here because the baby is now 2 months old. So it is very rare that Hirschsprung disease can present by this age.
So what is this? Right?
Yes, sir.
What it can be?
So it can be, sir, a short bowel syndrome. It could be due to the resection of the surgical neck at the age of the 4 weeks. So most likely. So
Short bowel syndrome presentation is different, and in short bowel syndrome, we usually doesn't need barium study. See the calibers of the bowel loops.
so it seems like
Yeah, Dr. Furkan told that it is these are strictures.
exactly.
Yes. So somehow, like all these scenarios, that sometimes maybe the baby had surgical neck or medical. So always remember, when the baby is being managed by medical neck, there is always strictures in the colon. Let me go to the next. Okay. So this is a 26 weeks gestational age infant with abdominal distension. Vital signs are stable except for diffusely dilated loops of bowel. There is no evidence of neck. The on-call team decided to take an overnight abdominal X-ray, which was otherwise, and continue the ongoing management. The next morning, the fellow informed the attending that the infant is much improved with reduced distension and bowel loops normalizing in caliber. Of the following, the preferred next step in the management of this infant is A, obtain an abdominal ultrasound to rule out neck. B, order another abdominal X-ray before morning round to aid in the decision to start trophic feeds. C, repeat the abdominal X-ray with 2 views. And D, share in relief with the fellow that the infant clinical status has improved. So this is the last question. So which one is any fellow can do the next step in the management of this baby? A common scenario as well. Or if you can identify in the X-ray what is wrong, then it is easy.
Dr. Osman, Dr. Furkan. Cherish went. What are the finding in the X-ray? Positive finding. Said?
So positive finding only a small, not small, but a large bowel loops seems to be dilated, like as sir in previous slides mentioned, like cubes. So cubes for me seems to be prominent. And और उसके अलावा सर इसके बाकी ये है कि नेमेटोसिस मुझे इसमें पता नहीं लग रहा है, आई डोंट नो, क्योंकि उसमें जो है ना क्लियर जो है ट्रांसम्यूरल वॉल जो है मुझे एक तो नजर आ रही है, लेकिन दूसरे में जो है ना मुझे लग रहा है कि इसमें है।
ग्रॉसली देखो वेरी प्रोमिनेंट।
दिल के नीचे हवा कब होती है?
जी सर,
दिल के नीचे हवा कब होती है?
हाँ सर, वो भी है ना, हाँ बिल्कुल ऊपर है। हाँ, तो ये नीमो मतलब वो है नीमो पेरिटोनियम।
तो क्या करोगे?
हाँ, इस कंडीशन में तो अगर है तो इस कंडीशन में नॉर्मली वैसे जो है हम जो रूटीन प्रैक्टिस करते हैं वो एक तो ये करते हैं कि हम कंफर्म, एक तो इसमें हो गया, वैसे हम लेटरल एक्सरे भी करवाते हैं इसके लिए, और दो यूज देखने के लिए। और मीनवाइल जो है हम कॉल देते हैं सर्जरी फॉर दी ड्रेन।
वो तो ठीक है, जो भी इस ऑप्शन में कौन सा आ जाएगा?
अच्छा, इसमें so another radiograph.
So anyway, so the answer correct here is C. Repeat the abdominal radiograph with 2 views. So it means that the baby is having spontaneous intestinal perforation.
So,
You can clearly see.
Naveed,
Ji, sir.
yeah, I want to ask you why you want to have a abdominal radiograph with two views. Repeat when there is a clear air here. What do you mean by two views? You mean lateral decubitus and all those?
Lateral cross table to just
Mhm.
confirm.
Ah,
It's
okay.
always like for management purposes, surgeons will always say that although
Yeah.
like it's clear, but the options given here doesn't
Ah,
go
okay.
further.
So, and why you don't want to do the abdominal ultrasound?
Because there are no signs of neck, and you cannot get any benefit on doing the ultrasound. It's already mentioned there in the scenario.
Mm-hmm.
There is a diffusely dilated loops, and there is no evidence of neck. If they have suggested something like pneumatosis or portal venous
Yeah.
gas, then
Mm-hmm.
so the clues were mostly pointing towards
This gas, air,
it,
yeah.
and the baby is otherwise vitally stable. So
Good. Yeah.
yeah.
I think it's very, very, very good. But actually, inshallah, whenever we do the next time, like MCQ things, then we have to discuss all four options. That we should learn more. I mean, and the people get more benefit. That why is not that, why is not that,
Actually, my
So
plan was to make it interactive in a way that everybody
I
will
know,
learn,
yeah, it's
but it
difficult
didn't
on
happen.
Zoom. Yeah, it's difficult on Zoom. But anyway, you did a very good job, Naveed.
Okay, so
One
now
question,
we are open for questions.
Nasir asking again and again that from where you take this question.
It's secret.
It's Nasir asking again and again in the WhatsApp.
Dr. Naveed,
Yes, now open for questions.
can you hear me?
Yes. Who is this Sajid?
My question is this the norm to have the MCQs like this in which you ask about this accept? Because my understanding is that nowadays there was something which was the old fashioned in which they ask which one is wrong. Nowadays, your MCQs are great. They are very, let us think on the options as well. But this pattern that when you ask this question, that which one of them is incorrect. Nowadays, do we have these types of exams?
It's like I'm not. It's just like a general question. So I don't know. Audience here might be not only
I'm
giving
just talking about the
FCPS.
junior
Some
colleagues because when they are appearing their exams, so do
No,
we have these
is
questions in exams?
to stimulate them thinking
yeah.
process.
Actually, if you're asking the pattern of the questions in the American way, yes, except question is still there, or most common, or they bold the word, like next step, accept this, or most appropriate, something like that. So still we are getting these questions, especially in the if you are doing, I'm thinking USMLE or any board, American board. So yes,
Okay.
this is a pattern, but I don't
Okay.
know
Thank you.
about other areas.
Okay. Thank you.
Mm.
Thank you so much, sir. Any participant want to ask the question? अगर किसी को
Yes,
कोई
I have a few questions in written format in the text. Can you
Okay,
see
yeah,
that?
I can see. I can. You want me to answer Sajid's question?
Sure, go ahead.
Okay. So the first question he asked that due to known phenomena of neurohormonal stress post major neonatal surgery, we see hyponatremia in reasonable number of neonates. To counteract, what is your strategy? Restricting IV fluid post surgery, or changing the strength from 1/5 to 10%, or dextrose saline half strength dextrose? So Sajid, to answer this question, mainly you can see the pathology here is the capillary leak you are dealing with. So it means that there are third spacing ongoing. So that baby sodium is actually normal, but it is factitious. So, and post-operatively, if there is a massive handling of the gut, the baby have a lot of showering of inflammatory markers and may result in hypotension, and you have to give inotropes. To me here, only normal maintenance sodium needs to be given, no need to change. And once the baby start passing urine and lose weights, he or she will improve the sodium. Question number 2 is, what fluid you recommend as IV fluid post-operatively while the baby is NPO? The normal maintenance fluid, what we give here is we prepare D10 water, and then we add about 3 to 4 MEQ per kg of sodium and 2 millimoles of potassium per kg and calcium. There is no special fluids. Number 3, rash and peristoma ulceration is very nasty and annoying in few babies post colostomy. Do you have any guidelines to address? Yeah, we have stoma nurse special who is assigned for this. Mostly this rash occur when baby has zinc deficiency. So we usually maintain zinc
Yes,
level.
okay. Just 1 minute. Sorry about that.
Okay. So usually we
Yeah, Naveed.
apply zinc oxide and try to keep the skin dry as much as possible.
Yeah, Naveed, the problem is when I came across cases, the problem is that even if you apply zinc, especially in Pakistan, when the parents, they are not as educated, they are not well informed, they go home. So only zinc oxide doesn't work, and you have to do some other strategies. I keep on asking the pediatric surgeons, do they have guidelines that sometimes you can put something like, which is oil based around that, so that water should not, touch the skin for long duration because it's soggy. Moreover, these secretions, they have got different pH. So even in Pakistan, they use a stuff which is called mercurium, something like that. They use that as well. I don't know what that stuff is. And then wash with the soap, because soap is a base, it's not acidic. So that's why I thought that it's good to have some information from your side, from your colostomy nurse, that what are the different strategies for nasty type of rashes in which one thing doesn't work and you have to do different maneuvers. And sometimes people, they start some feed thickeners, or I have seen some pediatric surgeons, they start some gastric dysmotility low dose, so that they want to increase this transient time, increase the gap. So many things are being practiced here. So because you are working in a
Sure.
very well advanced setup, that's why I asked, is there any guideline?
I will share with you the guidelines once I talk to that stoma nurse. Then sure, I will share. And finally, question number 4 is in gastroschisis, as feeding takes weeks to establish. So for resource restricted setup in Pakistan where TPN is not available, what do you suggest to handle this perplex situation where weight gain is a nightmare to achieve without TPN in babies with gastroschisis? So I think I understand that TPN is an issue. So rather than giving bolus feed, the best thing is to start small volume, continuous feed and slowly build up. But I don't have any other answer, because if there is no TPN, how can you give the calories?
Yeah.
So the best would be straight away start with this continuous feeds.
The problem is the cases which I came across, parents, they want answer whether surgeon can fix it or not. Pediatric surgeon comes and he says, okay, I'll fix it. And then they leave the baby, and that is with us. And now it's our job to handle all those questions and answers. And that's a big problem. So
Yes.
in these cases, what should do, whether surgeon should explain that, look, I can do the surgery, but as far as this long, lengthy, convoluted, unexpected course is concerned, if TPN is not there, so chances the prognosis is not great. That's the problem.
Yeah.
Can
I
I,
Yeah, I
Dr.
think it's a dilemma, and it's a situational. Whatever we have to go accordingly. But the thing is that there is no right answer for that. But as Naveed said, how you give the calories, that's the only way you can do it. And then sometimes the resources are so limited that those surgeries who have a very high complication rate, people avoid to do that, and the kid die. Actually, I'm sorry this is happening, but it is reality. In not only in Pakistan but many other countries, when they don't have the aftercare, okay, so the complicated surgeries they avoid to perform.
Yeah, so Dr. Judge, you just suggested, for example, if we come across a case when we have got background information that in the previous
Mm,
cases that didn't
mm.
work. So is it good to consult the parents, just giving time and tell
Yeah,
them that look,
a-
pediatric surgeon will
absolutely.
perform, but our experience says that this baby will have less chances. So is it ethical, do you
Absolutely.
think? Thank you.
Absolutely. So what happened, just happened in my unit here, not in USA. I just came back from USA. In UAE, we get the baby, and for some reason, most probably the genetic reason, he got the neck totalis, which is my fourth case in all my career. I saw it's so bad. The gut is mated. Our pediatric surgeon is very good.